Well, good evening, everyone. It's 7 o'clock. Just quick sound check. Perfect. Thank you very much. So, as always, we'll just give a couple of minutes just in case anyone wants to come along. Great to see the usual familiar faces in the crowd. Thank you all for coming along again. So this is the last of the ECG webinar series. We were talking about this today and wondering whether there was enough material really that could put together another ECG episode at the moment, and we kind of went with this. There's nothing particularly without going over a few things and adding in some really obscure stuff. We probably couldn't put together a whole hour's worth. And actually we are away next week as well, so there won't be a webinar next week. So we thought, well, actually with the natural break coming, it might be good to end ECG webinars and go on to a different subject. So we'll talk about more that later, but obviously tonight will be episode 8, so 8th week. That's gone very, very quickly. Good couple of months work gone into this. So this is Cardiomyopathy and Brugada tonight, so we're going to be talking about those. So welcome, as I say. Thank you all for coming out again, the usual crowd. So for those of you, there are a couple of names I haven't seen before, so welcome along. Thanks for joining us. Everything is up on our YouTube channel and on the CPD section of our website. So you're more than welcome to catch up with the previous 7 weeks after tonight, and of course tonight's will go up in the next few days. We had some technical issues last week, so apologies that it took a few days for us to get the recording up, but we got there in the end. So we've had our website redesigned as well over the last few days, which has slowed the process a little bit. So we are all up and running again there now. So for those of you that haven't met me, I'm an paramedic practitioner with a special interest in ECGs and cardiology in general. So we decided to put these together. STC Training Solutions was set up as a first aid training company. We've progressed into doing the FREC range of courses and clinical CPD events as well. And obviously we do BLS and ILS for healthcare professionals on the side of all of that. So there's a bit of a plug, shameless plug, of course. We're a commercial entity, so we are going to advertise our courses as well while you're all here before we get going. So predominantly we're providing FREC courses over the next few months. So if any of you are interested or know of anyone that's interested, then do get in touch with us. FREC 3, the next course on the 8th of July is fully booked with a waiting list. So the next course we're running will be the 29th of August. It's over 5 days, 3 weekends, 325 plus that does include medical gases as standard on all of those. So FREC 4, 395 plus VAT, only I think 1 or 2 maybe spaces left on the FREC 4 on the 8th of August. Do we know anyone that's keen on that? Next ILS is going to be running on the 2nd of August after the FREC 3 course. So if anybody's interested in getting their ILS done with us, more than welcome to pop along to that. And SARM, so we ran a SARM course last weekend, very popular. We had good feedback from that, and we do have another one coming up this weekend. We could do with a few more faces on that, so if you know of anyone that's interested in that SARM course, this weekend, 4th and 5th of July, is normally 165 plus VAT. We're going to knock 10% off that, so 150 plus VAT. The adverts will be going out tomorrow. If we know of anyone that's interested, get them to give us an email and we'll sort out that discount for them. So 150 plus VAT does include a copy of the JLCAT pocketbook, so that's good value for money if you know of anyone that's in the market for that. To save us having to cancel that course next weekend. So, and of course, no quibble refund policy if we do have to cancel the course for whatever reason. So that's the plug over and done with. Obviously, some of you may have seen on our website and Facebook as well, we've got the Zero to Hero range. So if you know of anyone that's fresh into this industry that wants to go through the FREC package at an affordable price, then we do offer the Zero to Hero range. With interest-free credit. So that's the advertising everything done with. So we'll go onwards with ECGs as we're just after 7 o'clock. It looks like everyone that's going to join is here. So again, let's make it interactive. This is the last of the ECG ones, but by no means the last of the webinars in general. So let's be nice and interactive tonight. So Charlotte's up online with the cat in Zoom chat. So Charlotte or Jake will reply. if you type in there. So you can WhatsApp us, you can tweet us, you can email us, and of course that's after the webinar has ended as well. If you're watching later on YouTube, do get in touch if you have any questions. We're going to use Mentimeter again this evening. Let's hope it works. We've had issues with that, haven't we, over the last few weeks. So the take-home point tonight is don't taunt the octopus. Hopefully that will make a little bit more sense a little bit later on in the evening. But if you don't taunt octopi, you won't get far wrong. So I like that this is an actual sign in Tokyo, I believe. So found on Google, but I thought that was quite funny. But it has got a relevance. So tonight, predominantly going to be talking about the cardiomyopathies. Now there are loads. I don't expect you to remember them all. You probably won't see many of them. Only realistically, it's only hypertrophic cardiomyopathy that we can really diagnose with ECGs. The reason I put them all in is because they are worth knowing. And certainly they're the cause, or the most common cause, of sudden cardiac death in younger adults, those that don't have other kind of structural changes or changes from poor lifestyle and diet, etc. So the big three, if you like: hypertrophic cardiomyopathy, used to be called hypertrophic obstructive cardiomyopathy. They've removed the word obstructive. We'll talk about why. Dilated cardiomyopathy and ARVC, arrhythmigenic right ventricular cardiomyopathy, are kind of the big three. They're inherited conditions. They're the most common of the cardiomyopathies, with hypertrophic being by far the most common. Takotsubo Cardiomyopathy is a little bit different in that it's a temporary cardiomyopathy in most cases. So we'll talk about what makes that special. And then there's the three specialized cardiomyopathies that you're not going to see very often, if at all. And actually they're quite poorly understood because they're so rare. So we're going to go through those. There's three of those that we'll go through. We'll talk about Brugada syndrome at the end today. It's more just having the pattern recognition. If you remember back a couple of weeks ago, we talked about De Winter's T waves. It's one of those things that you should spot. If you see Brugada syndrome or Brugada sign in a patient that's had a cardiac arrest or had an unexplained syncope, we need to take that seriously. And then of course the Q&A session at the end, where we can go through anything you want over the evening. So let's go onwards and upwards then. So let's cast our minds back to last week. So you've got a 17-year-old male collapsed whilst playing football, had a short syncope. The ambulance was called. He tells you when you get there that he feels faint when he stands. So we've got him lying down, and he's got a funny feeling in his chest, bit of fluttering going on. We'll get him up onto the ambulance. We get him plugged into the machine. So have a look at those obs. Quite clearly not brilliant, are they? So he's a little bit tachypnic. His sats are okay. Heart rate 288. Okay, and we do a double check, and that's real. We know we always doubt things when they come out like that. So we've got a 17-year-old who's collapsed playing football, the heart rate of 288, and a blood pressure of 58/35. That's why he feels faint standing up. So start to have in the back of your mind what you think might be going on in this case. Feel free to throw things in the chat. Lovely. There is a Mentimeter coming up, John. So hold that thought. So things start to improve. So you notice on the machine that his heart rate's coming down, his blood pressure's popped up a little bit. So he's still a bit tacky, 112, but blood pressure's settled. We can definitely deal with 112 over 288, can't we? So we plug him in, we get the ECG done. Rock and roll. Here's the ECG. I'm going to activate Mentimeter, so grab your smartphones. Whoops. Menti.com. The code is 406314 tonight. Menti.com 406314. You can it's one of those you can give up to 3 answers. So Charlotte's put the web address and the code in the chat. You can all have a look at that ECG. Given the history, 17-year-old boy playing footballs, collapsed, had a syncope, heart rate of 288, has now started to settle. You do an ECG and that's what you see. What are we starting to think of? Lovely. Keep throwing those ideas into the chat. Lovely. So we've got some ideas coming in here. I like it. Well done, everyone. Hypertrophic, right ventricular hypertrophy, hypertrophic cardiomyopathy, high voltage, peak T wave, peak tachy, peak QRS, POTS, postural orthostatic tachycardia syndrome is POTS, much more common in teenage girls than boys. Okay, typically you don't see speeds of 288 either. So I'm agreeing there is some high voltage going on there. There is peak T's, absolutely. There's some T-wave abnormalities going on there. So the majority of you, or most of you in the middle, are saying Wolff Parkinson White. Somebody said type A Wolff Parkinson White, which is absolutely the correct answer. Well done. This is type A Wolff Parkinson White. So it's an AV re-entry tachycardia, an AVRT, which can give very, very high speeds of up to 300 beats per minute. And as I say, it's that classical presentation of teenager exercise-induced syncope, very, very tachycardic on examination. You get your ECG slowed down. There's the short PR interval and the delta wave, classical of Wolff Parkinson White. This would be a great diagnosis to nail if you're out there on the road and you get a syncopial teenager that's been doing some exercise and passed out. If you nail this diagnosis, you're going to look really, really good. This is a really good thing to pick up. Certainly don't want to miss it. Certainly don't want to be sending that young lad home. High risk of non-sustained ventricular rhythms if Wolff Parkinson White is allowed to have its way. So likely to have problems such as VF and things like that, which of course we don't want any 17-year-old to have. So well done, everybody. Wolff Parkinson White, specifically type A Wolff Parkinson White, was the correct answer there. So we're going to talk about the cardiomyopathies now. So the big three, if you like, and of the big three, this is the biggest: hypertrophic cardiomyopathy, HCM. Okay, it used to be called hypertrophic obstructive cardiomyopathy, so HOCM. They've dropped the O because it's not always in only 25% of cases is in conjunction with some obstruction. And by obstruction, we mean to the left ventricular outflow tract, the LVOT. So we're going to talk about this. So HCM is a hereditary condition. And what happens, again, the process is poorly understood, shall I say. We're not entirely sure why. But these patients end up, over time, getting a gradually thicker and stiffer left ventricular myocardium. So you can see in the diagram on the right hand side, compared to the normal left ventricle, you get this swelling and bulging of the ventricular wall. Now, so classification is generally where this swelling, where this hypertrophy tends to occur. So the most common is the asymmetrical HCM. So asymmetrical being it generally forms on the septal wall, so a thickened ventricular septum, and that's what's shown in this diagram here. You can see the septal wall is very much more enlarged than the lateral wall of the left ventricle, although that lateral wall is slightly bigger. So when we look at kind of the same level of swelling or hypertrophy throughout the entire left ventricle, it would be referred to as symmetrical HCM. Again, that's rarer. And then the other kind of rare form is apical, where you actually only get the hypertrophy, the swelling at the apex of the heart. So at the bottom of the left ventricle is the only area which becomes hypertrophic. But the net result of all three of them is that the volume of the left ventricle decreases. Now, where people generally get confused, I'm going to pick up my pen and see if I can get that to work. So where people generally get slightly confused is with this term of obstruction. And obstruction refers to the left ventricular outflow tract, the LVOT. Now in health, your left ventricular outflow tract is this area here. So it's between the kind of the medial flap of the mitral valve, if you like, and the left ventricular wall on the septum. So this area here is your left ventricular outflow tract, and this is of course where all the blood is going to leave the ventricle and go up into the aortic arch. So in health, we have a nice wide LVOT. So in hypertrophic cardiomyopathy, what you can see is that you get obstruction of the LVOT, and that is both from the normal movements of the mitral valve. So don't forget, the mitral valve starts to open during systole to allow pre-filling of the ventricles, doesn't it? So that opening of the mitral valve combined with the swelling of the septal wall or the hypertrophy of the septal wall is going to cause this obstruction. So whenever you hear the term, so asymmetrical with or without left ventricular obstruction, outflow tract obstruction, that is what we're referring to. So if this LVOT is obstructed in any way, either through hypertrophy or through valvular movements, then it is referred to HCM with obstruction or obstructive hypertrophic cardiomyopathy. Now, it used to be they thought most people had this. It turns out this only occurs in around 25% of HCM patients, hence why they dropped HCOM or HOCM, depending on which books you read. So that's hypertrophic cardiomyopathy. So generally speaking, so what you'll hear is this term cellular disarray. So in the process of this hypertrophy and the thickening and the stiffening of the left ventricular myocardium, you get what's called cellular disarray. So the cells themselves aren't laid in any sensible format, and what this does is it makes them far more susceptible to producing their own ectopic beats. And remember, we've talked about those in previous weeks. And if they all start doing that, we get VF, don't we? So somebody in the chat mentioned about implantable cardioverting defibrillators, ICDs. That is the gold standard treatment for somebody with HCM, okay, because they are a very, very high risk comparatively to the rest of the population of having unstable ventricular rhythms, VF being the main one. So anyone with HCM and a history of syncope is absolutely worrying. That suggests that they've possibly had some form of unstable ventricular rhythm that's resulted in an acute loss of cardiac output. And obviously they've had a syncope. So and if that happens again next time, it could be VF. And of course, we generally don't come out of VF with a bit of electrical help, do we? So absolutely, the gold standard treatment for these patients is ICD, implantable cardioverting defibrillator. Just out of interest, I'm assuming everybody is of the age to be aware of Fabrice Muamba and what happened to Fabrice Muamba out on the football pitch. God, when was that? It must have been what, 5-6 years ago. Had a cardiac arrest whilst playing football. It took something like 23 shocks to get him out of VF, and he survived. He had undiagnosed obstructive HCM, and he had an acute run of VF, obviously, whilst he was playing football. So exercise-induced syncope, again, this is one of the absolute things we're going to look for. So how do we see it on an ECG? Get rid of my scroll, and I can move to the next page. Lovely. So here we are. So diagnostic criteria. So you're going to look for left ventricular hypertrophy. Quite clearly, the left ventricle is big. So the hypertrophic criteria in this ECG are the S wave in V1 plus the tallest R wave in V5 or V6 equals more than 35 millivolts. Quite clearly, you can see that the R waves themselves in V5 particular is what, 45 millivolts almost. So we've met the criteria without even including V1. So this is definitely left ventricular hypertrophy. And the dead giveaway with these is these Q waves. So Q waves we didn't really talk about too much. They come up in ischemia and things like that, don't they? So deep Q waves are generally associated with death of myocardium, but they tend to be quite wide in that process. These deep, narrow, dagger-like Q waves in these inferior leads, say 1, 2, 3. There and in your lateral lead. So if we have a quick look up here, so we've got a deep dagger-like Q wave, not so much in AVL, but there it is again in V5 and V6. These deep dagger-like Q waves are the giveaway for hypertrophic cardiomyopathy. This is one of those, it's like Wolf Parkinson White in his 17-year-old that's just collapsed playing football. If you're a 20-something-year-old that's just collapsed playing football and you find these deep dagger-like Q waves and left ventricular hypertrophy, don't forget, LVH can be perfectly normal. Fabrice Muamba would be expected to have left ventricular hypertrophy because he's an athlete. He's very, very fit. He does a lot of exercise. His left ventricle will be naturally and healthily hypertrophied. So that on its own isn't interesting. But if we saw the two, and actually one of the trainers actually that trained me in one of the ambulance services was one of the paramedics that was there when Fabrice Muamba had his cardiac arrest. and I'm led to believe that the post-ROSC ECGs definitely showed this evidence of hypertrophic cardiomyopathy. So unfortunately, we don't have anything available to show you on that. But that's an ECG typical of hypertrophic cardiomyopathy. Definitely don't miss that. It's one of those good things to spot in a post-syncope patient, and could well save their life if you notice it and if you get the defib in. So, and funny enough, all of the conditions we talk about tonight, the gold standard is implantable defibs. Even right the way up to Brugada, that's what we do with those patients. So the apical HCM that we talked about, most common in Japanese patients, I'm told, but I couldn't find any information on why. The dead giveaway is these giant precordial T-wave inversions. So left ventricular hypertrophy again, because it's the left ventricle that is larger. It's only the apex of the left ventricle that's hypertrophied specifically in apical HCM. And we're looking for these giant T-wave inversions in the precordial leads. That's the kind of giveaway. Don't forget, these can also be mistaken for Wellens waves. So remember the deep symmetrical T-waves in Wellens syndrome. That could be a post-MI finding. You can also see massive deep T-wave inversions in raised intracranial pressure. So these aren't the easiest things to spot. But in a patient that looks well, giant T-wave inversion could be a sign of apical HCM. So particularly if you're looking at a Japanese patient and there's any kind of history of syncope or cardiac failure, for example. So that's in there. So the next of the big three is the dilated cardiomyopathy. Now there's a couple of, again, none of these are particularly well understood. There's a couple of theories behind here. So one is that the bulk of these patients get this they inherit it. It's a hereditary finding. So there are definitely some pathophysiological kind of events that can lead to this as well. So the biggest that there's a lot of study going on to is kind of chronic severe hypertension down at the bottom of the list. And basically what the net result is with dilated cardiomyopathy is dilation, quite literally, of the left ventricle. The left ventricle stretches, it becomes baggy. Because you're stretching the myocytes, they're less able to contract. They lose their contractility, the ability to pump any kind of reasonable blood pressure. Slowly but surely, these patients have quite severe heart failure symptoms. These patients, if they're young enough, are going to be heart transplant patients. So, but obviously we know how long the lists are for that. That's not going to be an overnight thing. So there's some evidence that massive infarct is responsible for some of this. If you have a massive MI and kill a lot of your myocytes, they lose their contractility. The left ventricle can become baggy. So big inferior lateral MIs can cause this in theory. Myocarditis, alcoholism, autoimmune disease, and one of the other sort of specialist cardiomyopathies, the peripartum cardiomyopathy, nearly forgot my words there. They are peripartum cardiomyopathy is associated with dilation of the left ventricle as well. But again, the process isn't fully understood. But there's lots of different potential causes of dilated cardiomyopathy. It's not as common as HCM that we've just seen. But that's it. So lists along with due to COVID running at around 30% transplant operations compared to baseline. There we go. Thank you very much, Matt. They are, at the end of the day, it's not something you want to be waiting for, is it, a new heart? So baggy left ventricle effectively is your dilated cardiomyopathy, lots of potential causes. The symptoms that the patient are going to get are those of severe heart failure. So your breathlessness, your peripheral and pulmonary edema, fluid overload, lack of energy, etc., just poorly perfused in general. There's no real cure to it other than saying a heart transplant if the patient's young enough and well enough. So again, whilst this is an ECG webinar, there aren't that many ECG findings, and these are rare to see, these types of patients. So what are you going to see on your ECG with dilated cardiomyopathy? Well, quite clearly, it's enlargement of the heart in general. You're definitely going to see left ventricular hypertrophy, but actually in almost all cases, you're going to see biatrial enlargement. You're probably going to see some right ventricular hypertrophy. This is all because the left ventricle is now effectively doing nothing. It's a big saggy bag. So it's the rest of the heart that's causing what little cardiac output there is. So the rest of the heart becomes overworked and becomes hypertrophied. You're probably going to see left bundle branch spot morphology, not because there's a problem with the left bundle branch in electrical terms, just the left bundle branch has become so much longer because the left side of the heart is grossly enlarged. Low limb lead voltages, which is at odds with the hypertrophy. So if you imagine on the left side of the ECG, so leads 1 through to 3, and the augmented views are going to be low voltages, low millivolts, R waves and S waves. Whereas the right hand side of your ECG, your chest leads are going to be huge because you're going to have the left ventricular hypertrophy. Again, the reason why these patients suffer heart transplant is because there's no way of reducing their risk of having frequent PVCs. And we all know that frequent PVCs become NSVT, and if your NSVT can very quickly become VT if it doesn't stop. VT becomes VF, and VF we all know is not a great place to be. So these are again all of the things we're going to talk about tonight are associated with electrical instability within the heart and a willingness for the heart to go into these weird ventricular rhythms, which aren't conducive to healthy life. So these are, again, while I can't show you any decent ECGs of these because these are quite non-specific symptom findings. If you've got a patient with severe kind of cardiac failure symptoms, more if you're in primary care and these people come in and you don't know why they're getting such bad heart failure at such a young age, their ECG is showing symptoms like this, then we can probably look at DCM. Again, we're going to diagnose most of these things tonight on echo, Doppler echo, and looking at kind of outflow tracks and things like that to see where the problems are. So that's DCM, whistle stop. So arrhythmigenic right ventricular cardiomyopathy is the last of the big three. Again, it's another hereditary condition, and what's going on in this side? This is the only one of them really that specifically affects the right ventricle. Although they found in recent years with more and more study that's going on, I found some really interesting resources today actually on cardiomyopathy. So they're doing a lot of study into how these things happen. They're finding that it does actually affect the left ventricle, but it does seem to, for whatever reason, start in the right ventricle. It's a hereditary condition. It results in so the best way I had it described to me was if you imagine a brick wall is normally held together with cement. The bricks are the individual myocytes and the cements are the kind of connective tissues that hold them all together. Those connective tissues, the cement is missing. So you can imagine how much easier it would be to kick down a wall if there was no cement holding it together. So those individual myocytes aren't really held together. They eventually break down, and obviously when they disconnect from each other, they lose their kind of perfusion and they die. Those dead muscle myocytes are replaced by fat and scar tissue, which obviously doesn't contract, doesn't conduct electricity, doesn't work very well in a heart. So you lose very quickly your right ventricular ejection fraction. So you go into kind of acute and quite nasty right ventricular failure. So these patients aren't going to present terribly well. This is a fairly rapid decline, I'm led to believe, with these patients. Again, it's quite rare, but again, because of the instability that ensues, because the cardiac myocytes that are left become kind of disconnected from everything else, they become quite unstable, they become quite willing to fire off their own beats. These patients do have arrhythmias, not just ventricular arrhythmias, they can have atrial arrhythmias as well. So it's not uncommon to see AF in these patients. It's not uncommon to see obviously the VFs and the VTs that we're going to deal with. And again, these patients will have implanted pacemakers and or defibrillators to help them out. Again, quite a rare, but ARVC is there. And as I say, it can cause some bizarre rhythms. So the reason it's in here on the ECG webinars is because it's associated with epsilon waves. So if you ever hear epsilon waves being discussed, and ta-da, the epsilon waves are here. These are kind of quite specific to ARVC. Apparently they occur in around 30% of cases. So if you see epsilon waves in somebody with symptoms of right ventricular failure, you can probably start to think of arrhythmigenic right ventricular cardiomyopathy. So the epsilon wave is just a kind of a notching at the end of it. So it only really occurs in V1. It can be very, very easily missed, but that's that notching at the kind of the start of the ST segment is your Epsilon wave. It's very specific in that shape. We've got another example coming up in a minute. And this is kind of the final set of alternative lead views. If you remember very back at the beginning, I said there were 3 alternative lead views, 2 that you might use and 1 that you'll never use. This is the one that you'll never use. So you've got obviously your V4R in inferior MI, you've got your posterior leads in anterior wall depression. And these are the Fontaine bipolar leads. Okay, so these are specifically looking for Epsilon waves. They're very easily missed. Why would you suspect? I don't know, if you were doing an ECG on somebody that was quite young and quite well otherwise, and they were showing signs of quite significant right ventricular failure. If you were of the persuasion and thought about, oh, I wonder if it's AR, arrhythmigenic right ventricular cardiomyopathy, you might want to do these Fontaine bipolar leads. So basically, so the right arm, so the red lead ordinarily, this is where radial green bike doesn't work, because actually most ECG leads nowadays aren't red, yellow, green, black. So your right arm, what would normally be your red, goes in the center of the sternum. The left arm lead just down there at the bottom on the manubrium. Sorry, the xiphoid process. So the left arm. Let me start again. So the right arm lead goes on the manubrium, the left arm lead goes on the xiphoid process, and the left leg lead, rather than going at the top of the leg, goes into where V4 would normally go, so 5th intercostal space, mid-clavicular line, and then right leg stays where it is. That's your F point. Okay. And it gives these 3 different views. So F1, F2, F3, they would be called. So F1 is the one you're going to look for your Epsilon waves in. Okay. So obviously these will be in place of leads 1, 2, and 3. On the we've just got the cat trying to break into the caravan, so which is quite funny. So yeah, so if you're thinking along the lines of ARVC, then you might want to do the Fontaine bipolar leads, and this apparently just gives I've never done it, never seen anyone do it. I've never seen an Epsilon wave other than in training. But seemingly this just gives a more magnified view of what would normally be V1, but obviously it will appear where lead 1 would on your ECG printout. So you can look for these Epsilon waves. Here's an ECG with an Epsilon wave on. I'll give you just a second to find it. They can take different shapes, but it's just this kind of notching at the start of the ST segment. So you can see up there in lead V1. So you've got quite a wide QRS on this one. Bit of a sloping upslope to the ST segment, and there's that notching where the S wave would be at the start. Okay, lovely. So that is an Epsilon wave. This ECG, if you saw this with somebody with quite significant right ventricular RVF symptoms, then you'd definitely be thinking. So right ventricular failure, you're going to be thinking, yeah, you're going to be looking for the Epsilon waves. Okay, fantastic. So here we go then. So this is just a case study, just to see who's thinking about this already. So 45-year-old male, so already thinking possibly a little bit young, but chest pain, nausea, diaphoresis, cardiogenic shock, had a recent bereavement. So this chest pain is sudden. He looks unwell. You take some observations. They're not that bad. His observations are fine, aren't they, really? But he's got chest pain. He doesn't look particularly well. And you do an ECG. Okay. I'm going to just flick up to the next page. It's type your answer again. 406314. Charlotte's going to pop that in the chat again. Have a look at this ECG. So you've got a 45-year-old male. You can assume that he's otherwise fit and well. He's had a recent bereavement. He's got chest pain. He's cardiogenically shocked. He's looking pale, nauseous, sweaty, whatever else you want to chuck in there. He's read the textbooks. He knows how he should look. And you do this ECG. What are we going to do with that? So menti.com, 406314. It's in the chat. Have a little think. Pop some words in there. Oh. Anyone else want to have a go? Okay. Give you a minute just to pop some excellent, liking this, tube stones. Absolutely, Dave. Yeah, Dave nailed it. Just flick that back for anyone that's still trying to work that out. So 45-year-old male, chest pain, looks like he's going to be quite unwell. Chest pain and an ECG like this. Someone want to start throwing in the chat, 'cause it's not a question. Where are we going to take this patient? I like it. People are on the ball tonight. Where are we going with this patient? Throw it in the chat. Hospital. Be a little more specific, Matt. Co-op funeral service. I like your thinking. You've got the same sense of humour. Cardiac sensor, I'll take that, John. PPCI. Cardiology peoples. They're a strange bunch. KFC, help him get over his troubles. Cup of tea and a few biscuits, sort himself out. Relaxing bath and some candles. That's the cure, isn't it? No, so you're absolutely right, guys. This is Takotsubo Cardiomyopathy. Okay, so I can see why you're saying some of the other things that are coming up there. Papillary muscle. Okay, so there's an element of change to the papillary muscles, so I'll assume that's along those lines. So yeah, Takotsubo cardiomyopathy is of course the answer, and this is why you don't taunt the octopus. So Takotsubo is so called because the ventricle becomes the shape of an octopus trap, which in Japanese is Takotsubo, I'm led to believe. So that's why you don't taunt the octopus, because the octopus can kill you. So anyway, well, why that's in there? So Takotsubo versus MI, you're not going to be able to diagnose, and it's in red letters there. It's treated as an MI until proven otherwise. The only way you can prove otherwise is by echo. These patients will have abnormal ECGs, they will have chest pain, they will look like they're having an MI, they will have rose trops and myoglobin. So you cannot rule out, other than by getting them up on the table and doing PCI and having a look at their coronary circulation. These patients go to the cath lab. This is why it's called Takotsubo cardiomyopathy, because the left ventricle becomes the shape of an octopus trap, an octopus pot, a Takotsubo. It's also known as broken heart syndrome. The vast majority of cases they think are associated with stress. It's not known why some people are more prone to it than others. I read some statistics that perimenopausal women are the most likely to suffer Takotsubo cardiomyopathy that have had recent bereavements or significant stress. But there have been some cases of it happening after good events, although the example they gave was a wedding, and I wondered whether that was actually just a bit of truth setting in, perhaps, after the wedding, rather than that necessarily being associated with a good thing, who knows. But yeah, so Takotsubo cardiomyopathy associated with stress, it's a reshaping of the left ventricle. It's not very well understood. It's some kind of spasm of the myocardium. It's the only of the cardiomyopathies that will get better by itself. Doesn't always. I've got a patient on our caseload at the moment who has Takotsubo cardiomyopathy, and she hasn't reverted. She still has symptoms of left ventricular failure, although the chest pain and all the other symptoms associated that would make you think that this was an MI have gone, but she still has heart failure symptoms and an abnormal shape to her left ventricle. And it's been a couple of years, so I don't know what the thoughts are from cardiology that are dealing with her. So can you spot this on an ECG? You can't, John. That's what the ECG might look like. That's also an ECG that could easily be an anterolateral MI, couldn't it, or septal MI. So no, it's being aware that it exists. You can't differentiate it from anterior wall MI on an ECG, and actually there's even with bloods and echo, your gold standard treatment for these patients is PPCI. Have a look at their coronary circulation, make sure there's nothing going on. So again, thought to be caused by stress. It's known as broken heart syndrome, and it's a physical reshaping of the left ventricle to cause relatively restricted left ventricular outflow. Generally settles with time. As I say, most patients will get over this, but they do need a fairly good workup before we get there. So not an ECG diagnosis, unfortunately, but it does it's one of the MI mimics. So I'm going to talk about the three rarer ones. We won't talk about them in too much detail because they're so rare that actually they don't really understand what's going on with them. So one of the three rare cardiomyopathies is restrictive RCM, restrictive cardiomyopathy, and you can see this is the best diagram I could really find on it. If you look at the heart on the right hand side of the page there. It is thought to be a hereditary or a developmental defect. So they think that this starts to happen in utero as the heart's developing, that it has a defective gene that results in stiffening and scar tissue forming within the left ventricular myocardium. And again, we've talked about stiffening of the myocardium, reduces its contractility, reduces cardiac output. These patients are most likely to present with symptoms I've read in their kind of prepubescent years. So as they come up to 10, 11 years old is when you're most likely to see these patients present with symptoms. So there's some evidence that it's associated with hemochromatosis, so excess iron due to a GI malabsorption issue. Amyloidosis, so excess amyloid within the body, and sarcoidosis. All of these are associated or have been believed to be associated with restrictive cardiomyopathy. But again, generally these patients are younger and presenting, as I say, around puberty with symptoms of left ventricular heart failure, which obviously you don't expect to see in a child. Again, transplant patients. These are rare. Okay, so possibly I think I read that this was the rarest. So left ventricular non-compaction cardiomyopathy, LVNC. Okay, so rare that even Charlotte hadn't heard of it. So LVNC is again poorly understood. It's thought to be a genetic or a developmental defect. Effectively, the myos. So if you imagine your healthy heart on the left there, you have your normal muscle wall, your myocytes, myocardium is protected by a layer of endocardium, which is an endothelial layer, which is kind of impermeable, if you like, to blood and things along those lines. What happens is within the left ventricle specifically, and nobody really knows why, that endothelium is a little bit more susceptible to breakdown. And you get these, effectively the blood pushing its way through the endocardium into the myocardial walls and creating kind of channels from where, and it makes it's kind of described as making the left ventricle spongy. And you imagine if your ventricle becomes spongy, it's not going to contract with as much force, and you therefore get acute left ventricular failure. Again, not really understood. I couldn't find any real data on what it looks like on an ECG and when it's most likely to present. Although it did seem to be for more older patients because it just takes longer, and some patients have it and don't have symptoms. So these kind of little channels where the blood burrows down into the myocardium are called trabeculations. If you come across that term, it's referring to LVNC, left ventricular non-compaction cardiomyopathy. Bit of a mouthful, and very, very rare. And the final one, which we've already kind of briefly touched on, again, couldn't find any ECG bits and pieces on it, but effectively this is also reversible in most cases. So this is a very rare complication of late pregnancy and kind of shortly after postpartum, so up to 3 months postpartum. Ladies, particularly geriatric mothers, so those of over 30, 35 that are getting on for kind of the end of childbearing age are going to be more affected than younger mothers in this case. Again, it's poorly understood. Nobody really knows why. Nobody really knows what the differences are between geriatric mothers and young mothers, and why they're more susceptible to peripartum cardiomyopathy, PPCM. Effectively, what happens is the left ventricle dilates, so it becomes baggy in very much a similar way of dilated cardiomyopathy that we talked about earlier. But this reverses, and again, nobody really understands why. It can reverse over months to short years, but there's generally a good prognosis with it. But these patients are going to present late in pregnancy or early postpartum with again, symptoms of left ventricular failure, of congestive heart failure, which actually, if you think, a lot of women in late pregnancy are going to have some symptoms of heart failure. They're certainly going to have some symptoms of anemia and other kind of circulatory dysfunction. So actually spotting PPCM may be quite difficult. Postpartum, anyone presenting with heart failure, you're probably going to be thinking along these lines. Again, it is rare, probably not going to see it. It's going to be diagnosed with echo, and they're going to be managed pharmaceutically until the left ventricle starts to return to a normal size. So this isn't a permanent defect, and as I say, prognosis is good. I couldn't find any data on whether it's more likely to happen in repeat pregnancies, etc. But there you go, one of those. That completes the cardiomyopathies. So we can kind of go on to Brugada. So Brugada is again I thought Brugada fitted in nicely here because it's another symptom that's associated with arrhythmias. And again, the treatment for these patients is ECGs. So Brugada syndrome, what is it? So we talked about Brugada last week, didn't we? When we were talking about so the what's the word I'm looking for? So the Brugada pathway, if you like, wasn't it, when we were looking at VT versus supraventricular tachycardia with aberrancy. So Brugada syndrome is a calcium channel deficiency. Again, it's not fully understood why some people get it, some people don't. It appears to be hereditary. It appears to affect Southeast Asian patients more than any other group. So the one case I've seen of this was an Asian male in here. I think he was around 20, and I was called to him. So he'd had this diagnosed, but unbeknown to me at the time, obviously, and he'd had a fit, or been called for a fit. It turns out he wasn't fitting; he was in VF, and his implantable defib had already shocked him. And sure enough, when we turned up and shocked him a bit more and eventually got him back into sinus rhythm, he had Brugada, classic Brugada on his ECG. So of course we all, there were a couple of us that knew of Brugada, and we were all like, oh, this is exciting. It turns out he knew about it, so that took the shine off a little bit. We couldn't walk into Hammersmith Cath Lab and proclaim we have diagnosed Brugada, because we hadn't. He told us he had it. So, but we'd figured it out before he told us, so that made us feel a little bit better. But yeah, so that's the only time I've seen it. It was quite an interesting case. I used it as part of my CPD. So again, it's commonly associated with electrical conduction issues, because obviously the calcium channels aren't working properly. We know from week 1 that calcium channels are really, really important to coordinated heartbeats, etc. So the hearts are structurally normal. These are healthy patients. They can go well into their middle age without having this diagnosed. So the ECG changes can be transient. That's the hardest thing. So this patient, when we got to speak to him later on, had said that he'd had a couple of funny turns at school and ended up going to a doctor. It just happened to be a GP with special interest in cardiology. Ran some tests. Did some there's some drug-induced tests that they can do to try and stimulate the heart into going in, showing the Brugada sign, which we'll talk about in a minute. And that's how it was diagnosed for him. He had a really interesting case, but a very classic case for Brugada, that they have funny turns, and it's only generally somebody with special interest that picks up on it. Or if you're lucky enough to have one of these transient ECG changes at the time that somebody turns up and does an ECG and they happen to spot it. So the ECG changes, they can be brought on by fever, by ischemia. So again, if you're in an older patient that's probably got some heart failure, these patients generally, if this doesn't get diagnosed, they don't live long. So these patients need implanted defibrillators. Some drugs bring it on. Hypothermia can bring it on, so cold patients can show the Brugada sign, and hypokalemia. And as I say, there are some tests which they will do to try and elicit VT from the patients. You can imagine the ethics behind that debate of whether to put your patient into VT or not, just to prove whether or not they have Brugada. But hey, there we go. That's one of the tests they can do. So Brugada, what's it look like on an ECG? It's one of those things. Remember, we talked about De Winter's T's. It's a very particular pattern. You're just going to commit to memory. This Brugada sign on the left-hand side, type 1 Brugada, is the image you need to commit to memory. It's this very classic zigzag pattern in leads. So it can be in any lead V1 to V3. It typically appears in V1 and V2. The chap I went out to had a very, very clear Brugada sign in V1 and V2. So there's three types. Type 1 is the only diagnostic one. That's why it's in blue, and it's known as Brugada sign. So type 1 Brugada is Brugada sign. If you have that, and I'll talk about the other things you need, then you can diagnose Brugada syndrome. So type 2 is this very classical, if you look down in V2 in the middle there, that very classical saddleback ST elevation. So more than 2 millimeters in any lead V1 to V3. If you see that, that is Brugada type 2. That's not diagnostic of Brugada, but these patients are going to need cardiac workup. The cardiology are going to be very interested in these patients. And because Brugada is quite rare, they're going to be very interested. They're going to bring all the F1s, F2s, FHOs, registrars that haven't seen Brugada are going to be in tow with the consultant when he comes along to have a look at this ECG. Brugada type 3 is the non-specific one. It's kind of Brugada sign, but not meeting the 2 mil recommendations. Again, cardiology will look at that patient less urgently than perhaps a type 2. A type 1 is going into hospital. It's going up to be worked up by cardiology, most definitely. So you need, to diagnose Brugada syndrome, you need one of these in the history. Plus that type 1 Brugada sign. So if you see that on an ECG with any of these that's just happened, this patient has Brugada syndrome until proven otherwise, they go to cardiology. From an ambulance service point of view, it's not clear what they want you to do, certainly in the areas I work, whether you would go to a cardiac cath lab or whether you would just go to an A&E department of a hospital which has a cardiology department, which of course I can't think of any that don't off the top of my head. So obviously any patient that's had VF or polymorphic VT, so we talked about Torsades-Dupont being one of the polymorphic VTs. I mean, we're obviously taking these patients to hospital. That's a given, but it's just bearing in mind that this could be Brugada and actually cardiology are going to want to see this patient. So anyone with that sign and a family history of sudden cardiac death, so if any of their immediate family have died less than 45 years old, and they've had, and it's gone down as sudden cardiac death as the cause of death, these patients will need to be reviewed by cardiology. It's a hereditary condition. Similar ECG findings in their immediate family. So if you, this is probably where I think we joked in our SARM course last week, didn't we, about patients where you go in and you're so focused on doing observations, you go in and do observations and realize that's not the patient. Well, this is the classic example where you're going to do obs on somebody that's not the patient. If you go into a scenario and you find Brugada sign on somebody's ECG and their brother happens to be sitting next to them, you're going to ECG their brother too. So this is a hereditary finding. You're going to have then start working up the immediate family as a kind of preventative measure. So inducibility of VT, this is what we talked about. This would be the ethical dilemma, isn't it? Of do we give this patient a drug to put them in VT, or do we just assume they've got Brugada? Who knows? Syncope, so any patient that's fainted, and you pick up this. So my patient had supposedly had a fit. So they hadn't had a fit, they were just hypoxic from VF. So they had fitted, but not epileptic as they thought was going on. So that would class as a syncope. He does a syncopial episode, and obviously we'd had VF. So that patient was diagnosed with Brugada, and this. So for some unknown reason, they don't know why, but this in a lot of the kind of Nepalese countries and places like that, they call this I've forgotten the exact wording, but it's like the nighttime death disease. Most of these patients will go into Brugada overnight, and they can't quite figure out why. When you're in your deep sleep cycles, this is when you're most at risk of having the ventricular arrhythmias associated with Brugada. Again, there's no why, but that's most of these patients, if they're going to have VF, will have it overnight. Which of course really knackers your chances, doesn't it? Because unless your partner realizes, or if you obviously if you're sleeping alone, you've got no chance. So, but nocturnal agonal respiration. So there's some theory that these patients will have nights of kind of funny VT runs and things like that they come out of. And actually they'll have those agonal respirations at night. So it's quite classical of Brugada. So it's just one of those things. Sleep with the AED plugged in, yeah, absolutely, why not? It drives me a bit mad with stand clear analysing now every 2 minutes, but if you can sleep through that. But yeah, these are the kind of classic Brugada presentations. So if you go to a patient with one of these presentations, you whack on the ECG leads, you see particularly that one on the left hand side. Obviously, notwithstanding the patient that's had a VF, if you were thinking of leaving these patients where they are or sending them off on an alternative pathway, don't. Just readjust, bring your mind back to Brugada and get them seen by cardiology if it hasn't been diagnosed. If it's been diagnosed, they'll have an ICD. And this is what it looks like on a printed ECG, really classic Brugada sign there in V1 and V2. Memorize it like the Winter's teas, memorize it. It's something you don't want to miss, particularly in a post-syncopial patient or somebody that's had a cardiac arrest. If you see this type of stuff in your post-ROSC ECGs, it narrows down what's going on with this patient quite a lot. So that's it. That is, how do we done for time? So 4 minutes early. I worked on it. So that's a whistle-stopper cardiomyopathy, which I hope you found useful. I find it quite fascinating. I find Brugada quite interesting, more so because I've seen it and it was a fascinating case. So as I said at the beginning, that was the last of the ECG webinar series for now. We've been talking today about what we're doing next. So we're away next week. So this time next week, we will be hopefully sitting around a campfire with some bottles of cider on the go in the New Forest. So if anyone wants to come and join us, more than welcome. But we'll be down away from everything, hopefully. So obviously next week we wouldn't be able to do a webinar anyway. So we were thinking, well, this would be a time to change subjects. So from the 13th of July, we're going to start a new idea. So we're going to branch out into a few subjects. So the idea is the bulk of our customers, the bulk of our people that are tuning into this are going through, in some respect, the FREC pathway. So we're looking at putting together a group of ECG webinars specifically aimed at our FREC customers. We're looking to help those people that are looking to go from FREC 3 to FREC 4, and of course those that are going from FREC 4 to FREC 5. And of course those that have done their FREC 4s and want to do some CPD or vice versa, the FREC 3s. So we're going to start with a subject that I think will appeal to lots of people. We're going to talk about immediate life support. We're going to talk about what's involved, all the different types of things we can do for our patients, some of the latest evidence that's coming out with post-ROSC care and things along those lines. So I hope that will appeal to just as many people as the ECG series has, and I've been kind of humbled by how popular and how many good comments we've had with the ECG series. So let's hope that the next one goes off with a bang as well. So the first episode on ILS is going to be the 13th of July at 7 o'clock, so 2 weeks today. From there, we're proposing we're going to basically cover the FREC 4 syllabus, but we're going to open it up so we're going to start at the kind of FREC 3 level and then work up to kind of FREC 5 level. So we're going to try and help everybody along, all of our FREC clients along the way that are kind of going up through the ranks. And we'll talk about, obviously some of the extra courses and things like that you can do. So for those of you that aren't going to join in on the Q&A, that's it for tonight. Thank you very much for coming along. We hope to see you in a couple of weeks' time for the next series, if you like, of we're going to talk about not just obviously ILS. We're going to talk about We're going to do system by system reviews. I think Charlotte's going to take on some of these as well. We're going to cover basically the FRAC 4 course content in a theory lecture just to help people out. And then we're going to be looking at some other subjects in future. So these webinars are here to stay. We think that they're hugely beneficial. We're getting immensely, we're getting loads of good feedback, particularly from the people that are catching up on YouTube later. So we don't want to stop these. So provided there's still people turning up watching, we will carry them on. So they're not going anywhere. 2 weeks today, we'll do ILS and we'll go from there. Good. I'm glad they're popular. So if you'd like a CPD certificate for this evening, webinars at stctrainingsolutions.co.uk as always. If you're not going to stick around for the Q&A, then you are free to go. Please do leave us a review. Charlotte's put the links in the chat. It really does help us. As I say, we are doing this free of charge. But with the kind of secondary aim of trying to attract business to our paid courses as well. So the more reviews and the more kind of publicity we get out there in the great wide world, the better really. But of course we do this because we enjoy it as well. So there's the links. Okay, fantastic. So we're up onto Q&A then in that case. So first question in from Habiba. It's just disappeared off my screen. Okay, where are we at? So I'm just going to make sure I haven't missed any questions up there. Lovely. So I'm glad you're helping. Thank you to everyone that's leaving, and you're more than welcome for this evening. So you're welcome, Wendy. Big up the PAs. Good to see some of you there. So absolutely. So okay, Matt, you're more than welcome. Great stuff. You're more than welcome, John. Okay, so I saw Habiba somewhere. Where's she gone? Oh, there it is. How do you differentiate between Brugada and a PVC on an ECG? So with Brugada, let me bring it back to the ECG there. So Habiba, Brugada, if you look at it, with the big difference between, let me just get my pen up. So when you're trying to differentiate between what is a normal beat and what is a PVC, you need to have a look at where the beats kind of originated from. So if you look in an ECG that shows Brugada, we've got a P wave, we've got a QRS complex, and we've got a T wave, albeit they don't look normal, I grant you that, but we have P, QRS, and we have T, and we have P, QRS, T in every lead. So this is a sinus rhythm, so this can't be a premature ventricular complex. A PVC, don't forget, would come out of the middle of nowhere and it would look very different from everything around it, okay? So if you see something that doesn't have a P wave before it, it looks big, broad and bizarre, and it's kind of sticking out in the middle of nowhere, it's come out of nowhere, that's more likely to be a PVC. With this Brugada, it is a normal sinus, well, in this respect, this is a normal sinus rhythm. It just has Brugada aberrant conduction, so which are these Brugada signs that you can see in V1 and C2. I hope that makes sense, but a PVC is going to look very different from the QRS complexes either side of it, if that makes sense. Oh, more questions coming in. Good. See you on the 13th. Are there any specific heart sound finding in hypertrophic cardiomyopathy? Yes, so, good question, I like that, Ryan. Would there be an ejection murmur as in aortic stenosis, but due to left ventricular outflow, obstruction, S4 due to thickened, that's compliant? Great webinar. Oh, fantastic. So Ryan, it's going to depend on the cardiomyopathy. So really good questions, and I think you've kind of answered your own question in effect there. So what you've got to think about is in cardiomyopathy, particularly the hypertrophic cardiomyopathy, the most common one. If you remember when we looked back at that diagram, the mitral valve, don't forget the base of the left atrium becomes quite enlarged. So the mitral valve is perhaps going to become stretched and may not close properly. So you are going to get some mitral regurgitation. You're going to get, so your aortic valve can be normal in that respect, but with the obstruction of the left ventricular outflow tract, you may get some additional S4 sounds going on there. I'm thinking logically rather than from a knowing specifically the answer. If Charlotte wants to add. So yes, true. So regurgitation would be a pansystolic murmur, absolutely right, because if you imagine the mitral valve not closing properly, you would get a pansystolic murmur because the blood flow is flowing back into the left atrium during the whole of systole. That makes sense, doesn't it? So obstruction of the left ventricular outflow tract is probably going to cause additional pansystolic murmurs. It's not going to sound normal. I can't give you a definitive what you're going to hear in that case, Ryan, but you certainly sound like you're along the right lines. There would definitely be an ejection murmur. So not so much as in aortic stenosis. Don't forget, with aortic stenosis, you tend to get the click, don't you, as the valve kind of slams shut because it's not gliding smoothly as it would in health. That's true, yeah. And you get the Charlotte's just adding, you get the crescendo, decrescendo murmurs with AS. Or in any stenotic valve. Yep, that's true. I should just hand over to Charlotte for the Q&A for this bit. So you're more than welcome, Ryan. So I can't give you a definitive answer, and I don't suppose, thinking about it, I don't suppose there would be a definitive answer, because actually whether or not you have outflow tract obstruction is going to affect the sounds. Whether or not you get dilation of the base of the left atrium is going to affect how your mitral valve sounds. Your aortic valve, in theory, isn't affected, although of course these patients may have aortic stenosis, aortic regurg on top of all that's going on. But actually, the cardiomyopathy shouldn't actually affect your aortic valve, other than reducing the flow up to it through the outflow tract. Hopefully that answers it, but I'm glad you enjoyed it. So hopefully you'll join us for some more in the future. So why do you need a magnet to stop ICDs constantly firing? So yes, so we have ring magnets in the ambulance service that we put on ICDs. That's when they're inappropriately firing. So if you do, and I've been to a couple of patients where the ICDs have been misfiring. I can only imagine what that feels like for the poor patient, getting constantly shocked for no reason. And sure enough, you put some ECG leads on, and in between the shocks, they're in sinus rhythm. Then you cut out the ICD. We've had to do that. They, like every bit of machinery, they can misfire. That's the only indication to put the ICD on. The other time we sometimes use it is during cardiac arrest, if somebody has an ICD and they're not in a shockable rhythm, or we just want a clearer view of what's going on without the ICD going off every 30 seconds or 20 seconds, whatever they're set to. We sometimes turn it off and just use our own defibrillators. It's up to the clinician on the day, really, but that's generally the only times you're going to use them, is if the ICD is misfiring, but you don't want to get that wrong. You don't want to turn it off when they're actually in VF and it's doing what it should be doing. So big, broad and bizarre, might be, absolutely. So thank you. It wasn't pleasant. Yeah, I can imagine for the patient that was a really awful experience. I can't imagine what that'd be like. I suppose being paced when you're conscious would be similar to that, wouldn't it? But at least we try and sedate our patients before we TCP them. Any other questions? So that was that. Ryan answered. So Chris looking to do is FREC 4, brilliant. Well, we do have FREC 4s coming up, hint, hint. Fab. So difference between Wellens and Brugada. So Dave, Wellens are, so I don't think I'm going to be able to bring up a kind of picture reading. So don't forget with Wellens, you tend to get, actually we've got this picture in front of me here, where if I clear those drawings there. With what you see with Wellens, if you compare the two, is that when the how am I going to explain it? So at the end of your S wave, generally your S, so the QRS complex will end at the isoelectric line, and you normally get a normal ST segment before you get the biphasic T wave. Does that make sense? So you normally get that normal start to the ST segment, whereas with Brugada, it immediately kind of starts above the isoelectric line, and you get that concave ST elevation into a negative T wave. Whereas with Wellens, you're going to get a QRS that ends isoelectric with a relatively normal ST segment before you start to see your positive T wave into a negative deflection. So that's more Wellens, that's more Brugada. That makes sense. The beta angle I've not come across either. So you've heard about the beta angle. Ryan, I've not come across that. Don't know if Charlotte can do some quick research on that one for us.
I'm just replying to that.
We may have to look that one up, Ryan. I've not heard of the beta angle with Brugada. Let's have a look. See if it's anything I recognise. Okay. Fine. Okay. So, oh, the Chevalier angle. Okay. Fine. So, what the beta angle is, Ryan, is let's just clear that. Basically, so it's known as the Chevalier angle. So the angle is, if you were to draw a line from this point of the ST segment, effectively following, effectively obviously this is slightly concave, so you can't draw a straight line. But if you drew a straight line from that point, kind of running perpendicular to this concave ST segment, if it was running in a straight line, if you measured that angle from the how would I describe it? So if you imagine, so we just talked about Wellens, didn't you? So normally your QRS complex ends up at an isoelectric line, and your ST segment runs perpendicular to the QRS complex. So it runs it effectively at 0 degrees, isn't it? So this angle here, so the angle between, so the Chevalier's angle is if you drew a line from there to there. So basically the higher this angle, the more likely this is to be Brugada. The lower the angle, the more likely it is to be just some other form of aberrant conduction. That's my understanding of Chevalier's angle. I don't know if that helps you in any way, but basically pop a point there, run a line kind of parallel to the ST segment, measure that angle from the isoelectric baseline, and that would be your beta angle, Chevalier's angle. It's a way of increasing the sensitivity of the ECG in diagnosing Brugada. If you pick up anything that looks like Brugada in a patient that has any of those prodromal symptoms, no, you're more than welcome. I like to be tested as well. So Andy, that is on the to-do list. We just haven't had a chance to do any of the. So Andy's asking for kind of crib sheets. It was very much. It was very much on the cards from the beginning. We only managed 2 weeks of keeping up with the handouts. Unfortunately, they're quite labour intensive to get them right and make sure we reference them and we double check everything we're putting on there is correct. So. So they will appear. Certainly, I think as we go through the next weeks of CPD, kind of generic topics, I think it'll be quite easy to keep up. So no problem, Andy. We know it's been asked for. It's definitely something I want to provide. So if it looks like a duck, walks like a duck, quacks like a duck, then treat it as a duck. Absolutely. Just maybe want Chinese now, Matt, unfortunately. Hey, more than welcome, Aviva. Absolutely, a week off. Well, that's it. So, oh yes, now you're talking. I think when you're back for the ILS, Matt, we'll do a Chinese. Duck Lives Matter, they do. March 2020. I don't think I can wait that long. when we come up to look at bases in the north. Good. Yeah, we've got a couple of good Chinese takeaways. Anyway, so let's stop talking about Chinese. I'm trying to diet. Okay, Manchester. Fair. Yeah, we could be tempted to Manchester. So we're looking to start bases in the north of England. So watch this space. Do you know, I've never been to Manchester actually. Other than I went for a job interview once upon a time, but I've never actually been into Manchester. So that could be. I'll stop the recording there because I'm only going to end up cutting this bit out anyway. So